So, in this third part of our presentation, I want to talk about the what of dietary treatment of IBS. Please remember that dietary treatment of IBS, which aims at reducing poorly absorbable carbohydrates, plays an important role in the treatment of IBS. In this part, I want to focus on which dietary approach should be chosen, the precision knife approach or the shotgun approach, in which group of patients is detection of specific intolerances important, and why is it important to differentiate between carbohydrate malabsorption and intolerance. We have in the second part of my presentation heard about the unresolved questions in low FODMAP diet. Unresolved long-term efficacy, patient compliance, and the potential adverse effects on the microbiome, on costs of living and quality of life, on nutrient deficiencies, and on other diseases related to low-fiber diet like vascular diseases, colon carcinoma, or diverticulosis. I have pointed out in the second part of my presentation also that lactose is an important component of the FODMAP group, and this can be nicely shown in this study in IBS patients who received the baseline diet, followed after 3 months of FODMAP diet, and then another 3 months of re-challenge diet. Now, lactose was approximately 60% of the total FODMAP content of 28 grams, both in the baseline diet and in the adjusted FODMAP diet. The FODMAP reduction of 16 grams from start during the low FODMAP diet is composed of a reduction of 9 grams of lactose and only 7 grams of non-lactose carbohydrates. We have to return to this piece of information. Because of the high worldwide prevalence of primary lactase deficiency, there is a large potential for lactose intolerance causing symptoms in IBS. The reduction of lactose as a part of the FODMAP diet, therefore, seems at the first glance to be very reasonable. However, the prevalence of lactase deficiency has great regional variations. And this raises the question whether a low FODMAP diet should be the same in every region, should be the same in regions of high prevalence of lactase deficiency as in regions with low prevalence of lactase deficiency. In fact, why should IBS patients who tolerate lactose be submitted to low FODMAP diet in which the major component is restriction of lactose and therefore unnecessarily impact on quality of life, costs of living, nutrient supply due to restriction of milk products? And on the other side, why should IBS patients with lactose intolerance be submitted to low FODMAP diet, which includes dietary restriction of other poorly absorbable carbohydrates, and make diet much more complicated to follow? So what should be a reasonable approach to dietary treatment of IBS? Should it be a precision knife approach or a shotgun approach? Should it be identification of specific intolerances followed by specific dietary exclusions of like lactose, fructose, starch, or sucrose? Or should it be broad and unspecified approach with a low FODMAP diet? You might raise the point that studies on the treatment of lactose malabsorption have not provided definitive answers on their effective studies, including lactose-reduced or hydrolyzed milk, lactase supplements, probiotics, colonic adaptation, or rifaximin. However, please consider that these studies are burdened by no upfront definition of and distinction between lactose malabsorption and intolerance, by poor patient inclusion criteria, no reproducible validated assessment criteria, and no defined outcome parameters. And we need to keep in mind that the development of symptoms after lactose ingestion is dose dependent and dependent on other food components. If lactose is ingested as a single dose without nutrients other than milk, lactose doses below 20 grams may cause symptoms, whereas if it is ingested with nutrients, then it is only lactose doses above 30 grams, which may be responsible for symptoms. It is important to understand the differences between lactase deficiency, lactose malabsorption, and lactose intolerance, and to correctly use these terms as suggested by the recently published European guideline. Out of this follows the need to identify intolerances in IBS patients, especially in countries with lower prevalences of lactase deficiency, which are the countries in the green shades. And for this purpose, a validated symptom questionnaire, the Adult Carbohydrate Perception Questionnaire, ACPQ, has been published and also suggested in the European guideline to be used in the detection of lactose intolerance. Why is it important to be aware of the difference between lactose malabsorption and intolerance? Why are the demonstration of enzyme deficiencies with genetic testing or mucosal enzyme activities, the demonstration of hypomorphic enzyme variants by genetic testing, or of carbohydrate malabsorption by breath testing not enough to explain the cause of symptoms in IBS patients presenting with symptoms, and not enough to recommend treatment with lactose reduction? We have previously reported the discrepancy between results of hydrogen breath tests, which are used to demonstrate malabsorption, and the assessment of burdensome symptoms with the ACPQ after lactose challenge in more than 500 patients. In 226 patients who had malabsorption demonstrated by a positive hydrogen breath test, 29% of these patients had no burdensome symptoms. And out of 310 patients with a negative hydrogen breath test, which excludes malabsorption, 41% had burdensome symptoms after lactose challenge. So malabsorption alone is not a sufficient explanation for the development of symptoms after ingestion of lactose. Additional factors presumably play a role in the pathogenesis of symptoms, like increased intestinal sensitivity to the malabsorbed substrate or the products of its bacterial metabolism. Identification of carbohydrate intolerances with the ACPQ identifies patients with lactose or fructose intolerance who respond to diet. In this study, we assessed scores for individual IBS-related symptoms before and after a 2 to 3 month lactose or fructose reduced diet, and the symptoms before the diet are shown in the black column, after the diet are shown in the gray column. So the adult carbohydrate perception identifies those patients who respond to diet. The future of the diagnosis of carbohydrate intolerances in the 21st century does not lie in paper-based questionnaires, but in electronic devices. And therefore, we have transferred the validated and published ACPQ into a medical device, a CE-certified app with the name of Carboception. This allows home-based testing independent of doctors' offices or outpatient clinics testing of a wide variety of sugars and carbohydrate-containing foods at different doses, tests to be performed under different life conditions, like at home, at workplace, during vacation, during different phases of menstrual cycle, all life conditions which are known to affect symptomatology in IBS. However, carboception is currently available only in Austria and Germany, in German languages, but we are working on distributing it in all of Europe. Let me summarize the role of carbohydrates in IBS. Poorly absorbable dietary carbohydrates contained in healthy diets are an important source of symptoms in IBS. This may be monosaccharides and sugar alcohols like fructose, sorbitol, mannitol, xylitol. This may be disaccharides like lactose or trehalose. This may be oligosaccharides and polysaccharides like fructans, starch, pectin, dietary fibers. And some of these carbohydrates are grouped as FODMAP. Well-absorbable carbohydrates may be made poorly absorbable due to various pathogenetic mechanisms like enzyme deficiencies in lactase or trehalase deficiency or hypofunctional enzyme variations. Enzyme deficiency or malabsorption may precipitate the development of symptoms of intolerance, but symptoms of intolerance may develop without malabsorptive or maldigestive mechanisms. A focus on the detection and treatment of specific carbohydrate intolerances is warranted and possible with the use of validated symptom questionnaire ACPQ. Finally, let me summarize the why, which, how, and what of dietary treatment of IBS. Why diet? Well, it has been shown to be better than pharmacological treatments. Which diet to choose? Incompletely absorbed carbohydrates are the most common food components causing symptoms. Consider the pros and cons of shotgun FODMAP approach versus precision knife approach, which is the reduction of specific food items causing symptoms. For this, consider the ethnic background for the likelihood of lactose intolerance. If the likelihood is high, start with a lactose-reduced diet. If the likelihood of lactose intolerance is low, do intolerance testing to identify food components and intolerable doses with the ACPQ or the Carboception app. How shall dietary treatment be administered? Well, identify the tolerable dose rather than totally excluding food components, and pay attention to keeping a balanced diet and avoid deficiencies. And what shall be observed? Observe long-term consequences of shotgun low FODMAP diet on the microbiome, on nutrient deficiencies, and safeties. I want to invite you to access additional information on the previously recorded WUMEDI video on lactose intolerance or on our Carboception channels on YouTube or Instagram. Thank you for your attention.